Hello everyone. Today we are going to study the topic of extraaxial hemorrhages. But first, we need to know the meningeal layers. There are three layers: dura mater, arachnoid mater, and the pia mater. The dura mater is divided into two: the outer dura mater and the inner dura mater. There are two types of extraaxial hemorrhages: the epidural hematomas and the subdural hematomas, EDH and SDH. Epidural hematoma is basically the collection of blood between the calvaria and the outer periosteal layer of dura mater. And subdural hematomas is a collection between the dura mater and the arachnoid mater in subdural space. Now we will study in detail extradural hematomas. Extradural hematomas are mostly associated with skull fractures. 90% of the time they are arterial, and the most common artery involved is middle meningeal artery. But in 10% cases they can also be venous. The clinical course involves the classic lucid interval only in 50% of the patients, and there can be delayed deterioration also. Now, the classic arterial EDH, the CT findings we see is a biconvex hyperdense collection which is limited by sutures. But this collection can also cross the midline. For example, say if there is a EDH, frontal EDH, we can see that if there is a EDH over here, that it is limited by sutures, but it can cross the midline. But in some cases, mostly in children, if EDH is associated with sutural diastasis, then it can also cross sutures. Sometimes we can also see ear foci within these hemorrhages. Sometimes we see a hypodense collection within the bleed. What does this indicate? This indicates that active bleed is going on, and this is known as swirl sign, and this is associated with adverse outcome. But there are also other features which might be associated with adverse outcome. If the thickness of EDH is more than 15 mm and the volume is more than 30 mm and the midline shift is more than 5 mm, 15 mm, 30 ml volume, and the midline shift of 5 mm, and the swirl sign, as we has discussed, all these features are associated with adverse clinical outcome and might need some surgical intervention. Now we will study venous epidural hematomas. These are generally caused by skull fractures that crosses the dural venous sinuses, and these can be limited in size and can be treated conservatively. There are basically of three types: vertex EDH, anterior temporal EDH, and clival EDH. We will study each of them in detail. First of all, vertex EDH. Vertex EDH is caused if there is a fracture line which can be seen crossing the superior sagittal sinus. Now in this image we can clearly see a collection which is compressing the superior sagittal sinus, and the hypodense foci within the superior sagittal sinus indicate thrombosis. See, this is also a case of vertex venous EDH in which we can see that the EDH is crossing the midline, then the superior sagittal sinus it is displaced, and the hypodense areas within indicate the thrombosed superior sagittal sinus. Now anterior temporal EDH. Anterior temporal EDH is generally associated with fractures of greater wing of sphenoid or tripod fractures, as these fractures lead to injury of sphenoparietal sinus, and this venous bleed is mostly limited by orbital fissure medially and sphenotemporal suture laterally. In this image we can clearly see a biconvex anterior temporal epidural hematoma. This represents anterior temporal EDH. This has a benign clinical course. Then clival EDH. Before studying clival EDH, we need to know some anatomy. First, we will study the anatomy of tectorial membrane. Tectorial membrane is basically the upward extension of posterior longitudinal ligament. Then it is fixed to the posterior surface of body of axis, and then as it advances further, it blends with durameter ultimately. The blue line represents the tectorial membrane and the yellow line represents the durameter. Now, what is retroclival epidural space? Basically, the red line here between the tectorial membrane and above the durameter, this represents the retroclival epidural space. Now, retroclival epidural hemorrhage. Now, what happens? This hemorrhage is most common in children. In children, if there is any injury to neck, the hyperextension or hyperflexion injury to the neck, this will lead to stripping of durameter or stretching of durameter, and during this process there can be injury to the basilar venous plexus or any veins which are present in close relation to the clivus. This will lead to hemorrhage, and we can clearly see that the hemorrhage is located posterior to the clivus but anterior to the durameter. It might lie anterior or posterior to the tectorial membrane. Inferiorly, the hemorrhage is limited to the C2 level because here the tectorial membrane blends with posterior longitudinal ligament. Okay, now we can clearly see that it is written, it is a traumatic disruption of tectorial membrane or other ligaments from hyperextension or hyperflexion injury, and the traction applied during the stripping of tectorial membrane can shear the nearby vessels of basilar venous plexus. MRI is superior in evaluating because it can also evaluate the ligamentous injury. Now we will see the CT image. See, here we can clearly see the clival EDH. The same here in this image we can also see the clival EDH, and this clival EDH can also be associated with multiple cranial neuropathies, but the most common is abducens nerve because we know that here the abducens nerve is passing through the Dorello's canal. Usually it has a benign course. So this was a topic of EDH. In next class we will study the topic of subdural hematomas. Thank you.